Hereby I open this academic ceremony at Maastricht University. My name is Ton de Goeij. I am the pro-rector of the ceremony and chair of the degree committee. First of all, I would like to welcome Mr. Rezazadeh Ardabili. He will defend his thesis in public, and his thesis is titled Towards Comprehensive Disease Control in Inflammatory Bowel Disease, the right treatment for the right patient. Welcome all members of the degree committee, and I welcome in particular the three supervisors sitting opposite to me. And I miss one paper. Heb jij nog een papiertje? Dat heb ik laten liggen. Thank you. From left to right for me and for you as well. Professor Daisy Jonkers, she is professor of healthy bowel. Professor Pierik, Marieke Pierik, she is professor of real-world data of inflammatory bowel disease. And Dr. Romberg-Kamps, and she is inflammatory disease specialist at Zuiderland Medical Center in Sittard. I will introduce the 6 opponents later during the ceremony, because if I read all those names you will certainly forget, so I do that later. And I would like to welcome the audience here in the aula, and in particular I welcome the extensive family of the candidates today. And I also welcome all the followers of the live stream. I would like to invite you to give a summary of your thesis, and I would like to wish you success in the coming hour. The floor is yours.
Thank you, dear Pro-Rector. Dear Pro-Rector, dear Corona, dear family, friends, and colleagues, both on-site and online, I'm very pleased to be standing here in front of you today. In the next 15 minutes, I will try my best to share the main messages of my thesis, entitled Towards Comprehensive Disease Control in IBD, the right treatment for the right patient. Inflammatory bowel disease, in short IBD, is a chronic inflammatory condition of the gut, characterized by periods of active disease and inactive disease, also called remission. IBD includes Crohn's disease and ulcerative colitis, which you both may have heard of or actually know someone living with the disease. Crohn's disease can manifest throughout the whole gastrointestinal tract, but is usually located at the end of the small bowel or the beginning of the large bowel, whereas ulcerative colitis is limited only to the large bowel. IBD is a disease of the young, with most people being diagnosed in their early 20s. But we also see a peak in diagnoses around the ages of 50 to 60 years old. And currently, roughly 100 to 120,000 people in the Netherlands live with IBD, and this number is increasing, making it not just a medical, but also a societal challenge. The typical symptoms that someone with IBD experiences include abdominal pain, diarrhea, often accompanied with blood, and fatigue. And you can imagine that if these symptoms go on for longer periods of time, they can also strongly affect mental health, including anxiety and depressive symptoms. Since we currently don't know the exact cause of IBD, our treatment is focused on trying to tackle the inflammation. And we basically have 2 options, one of which is anti-inflammatory drugs, and the other one is surgery. And anti-inflammatory drugs are drugs that target the immune system by basically turning down the volume button. Most of our treatments have a systemic effect, meaning they suppress the immune system throughout the whole body. And this can make people more prone to catching infections too. And on the other hand, we have surgery, which is less often performed in comparison to using drugs, but can be very useful, either right at diagnosis or later in the disease. To explain what we've tried to do in my thesis and what I mean by towards comprehensive disease control, I want to show you the journey of a typical IBD patient. You can see that patient is diagnosed, and we try to give medication to get the disease back into control. Actually, you can see the ups and downs along the way. In fact, it resembles a ski track, just like the one on my cover. Sometimes the slope is smooth, sometimes there are difficult bumps, and the track is never entirely predictable. And the blue line in the middle represents remission. And ideally, we want to keep patients skiing steadily under the blue line. But the problem is that at key points along this track, we lack predictive power. At diagnosis, we don't know who will develop a mild or severe course, and during remission, we cannot predict who will relapse. That is why, in part one of my thesis, we focused on improving our ability to predict outcomes and to evaluate how effective our treatments are in practice. Of course, effective treatment also comes with potential downsides. We constantly have to balance benefits against risks, and in part two, we therefore looked at treatment safety, with particular attention to infections. And even when inflammation is well controlled, many patients still struggle with persistent symptoms. And these are often overlooked, but strongly affect quality of life. And in part three, we address these issues beyond inflammation. No research is possible without the help of patients. So what data sources did we use to try answer our questions? First, the IBD South Limburg cohort, founded in 1991, and includes virtually all newly diagnosed patients in the region. And because patients are followed up for long periods of time, this gives us a unique opportunity to study the natural course of the disease. And currently, it includes almost 1,200 Crohn's patients and over 1,600 ulcerative colitis patients. Second, we use data from the MyIBD Coach cohort, an online telemedicine platform implemented across more than 20 hospitals across the Netherlands with more than 10,000 patients using it. And the patients fill out several questionnaires every couple of months on topics related to their disease, but also related to work, mental health, and lifestyle. And with that, we can monitor them from a distance. For part one, we made use of the IBD South Limburg cohort. And for parts 2 and 3, we made use of the MyIBD Coach cohort. So, part 1, we're at the very beginning of the ski track, where we want to predict how the journey will unfold and how effective our treatments are in keeping patients on track. And to better understand why prediction is so important, it's crucial to realize that not every patient with IBD follows the same course. Here you can see 3 examples of how disease may evolve over time. On the vertical axis, you can see the amount of active disease, and on the horizontal axis, the years after diagnosis, up to 10 years. And from our previous work from our group, we know that roughly 1/3 of patients will follow a mild course, 1/3 a moderate course, and 1/3 will follow a severe course. And this is exactly where prediction becomes essential. If we could reliably identify the group with a mild course, some of these patients might not need treatment at all. And without that information, they may risk overtreatment. On the other hand, patients with a more severe course may need more aggressive therapy early on and may be at risk of undertreatment. Every patient at diagnosis undergoes a colonoscopy with biopsies. In Chapter 2, we ask whether looking at these biopsies under the microscope could help us distinguish between a long-term mild and long-term severe course. And for this study, we revisited those diagnostic biopsies in 137 Crohn's patients from whom we already knew the long-term outcomes. And 2 pathologists then independently scored 15 features in more than 800 biopsies. And what we found was that certain features of chronic inflammation, meaning changes that show the inflammation was there already for a while at the diagnosis, were associated with developing a severe course. So even very early, at the moment of diagnosis, there may be signals already in the tissue that can tell us something about the long-term outlook. If evaluation of biopsies helps us to tell us who's at risk, the next question is, what do we treat them with, and how well those treatments actually work in practice? And this slide shows you the treatment options we had before the year 2000. And for many years, we only had a limited toolbox available. And from 2000 onwards, the number of available treatment has expanded enormously. And this expansion has been very valuable for our patients, but that also made decision-making much more complicated. Which drug should we use for which patient, and when? And are older, more traditional drugs like thiopurines still effective enough to use now that we have all these newer agents? And this last question is actually what we wanted to address in the IBD South Limburg cohort. So in Chapter 3, we studied the effectiveness and safety of thiopurines. And thiopurines are immunosuppressive drugs that are available in 3 forms that you can see on the left picture. And in our study, we included over 1,000 patients who had started thiopurine between 1991 and 2014, and these were followed up to 15 years. And we found that over 40% of these patients were still using a thiopurine at 5 years without the need for more potent drugs, hospitalization for active disease, or surgery, which is a high percentage. And we also looked at safety, and the safety profile we observed was similar to what has been reported in literature. Taken together, we concluded that thiopurines, even in the era with many newer and more expensive drugs, remain an effective, safe, and durable treatment option for patients with IBD. That brings us to part 2, further down the ski track, where the challenge is no longer just about moving forward effectively, but also staying safe on the way. On this balance, you can see the two sides, effectiveness on the one hand and safety on the other. And with the growing number of treatments, choosing the right therapy has become much more complex. It's no longer just about safety, about effectiveness. Safety has become an equally important factor. And when we talk about safety, we usually mean 3 categories of risks: cancers, cardiovascular events, and infections. And in my thesis, I specifically focus on infections. So that is what we will zoom in on now. And when we talk about infections, we usually divide them into 3 categories: mild, moderate, and severe. Mild infections are those that go away on their own or only need something local, like a cream. And moderate infections are those that need oral medication, for example, antibiotics. And severe infections are those for which someone needs to be admitted to the hospital or needs medication via the blood. Now, for these severe infections, which are relatively rare, we already knew quite a bit. But for these mild and moderate infections, there is almost no data at all. And we thought this was unfair, because these milder infections can still have a large impact. In fact, many patients report them as the most burdensome side effect of their medication. But the problem is that these mild and moderate infections were never systematically recorded, and there is no structured way to capture them. And that is why we performed a PRIQ study in chapter 6 and 7. Before we could study these infections, we first had to develop a tool to actually capture them, the PRIQ, Patient-Reported Infections Questionnaire. And in chapter 6, you can see that in the orange diagram, we followed a rigorous process with literature review, expert input, and patient interviews until we had a final version. And the interesting part is the final product, the PRIQ, a short 7-item questionnaire covering 15 infection categories that patients fill out every 3 months. Of course, if you develop something, you also need to make sure that it measures what you intended to measure. So we validated the PRIQ by implementing it in my IBD coach and studying it in almost 600 patients over time. And we cross-checked patient-reported data against the gold standard, data from general practitioners, pharmacy records, and hospital records, where infections would normally be documented. And the results were very reassuring. The PRIQ showed excellent agreement and accuracy, and this meant it was ready to use for the real fun part, studying mild and moderate infections and their risk factors. So in total, we collected data from 629 IBD patients who regularly filled out the PRIQ over 1 year in my IBD coach. Altogether, this resulted in almost 1,000 infections. And as expected, mild infections were by far the most common. On average, each patient had a little more than 1 mild infection per year. And moderate infections occurred less often, and severe infections were relatively rare. When looking at risk factors, we found that certain groups were at clearly higher risk: women, patients with multiple diseases, smokers, and of course those using anti-inflammatory drugs. In particular, drugs such as prednisone stood out. They more than doubled the risk of infections. And these findings provide important insights to help us personalize treatment, carefully balancing effectiveness with safety. So as we move further down the ski track, we realize that controlling inflammation and staying safe is not the end of the journey. Because even if we succeed in doing so, many patients still come back and face another challenge down the track: persistent symptoms in remission. Even when inflammation is under control, patients keep coming back asking the same questions. Why do I still have so much pain, doctor? I thought my bowels were healed. And in fact, these are not isolated cases. We know that about 30 to 50% of patients still have symptoms without any signs of active inflammation. So controlling inflammation is only one part of the story. The other part is how we deal with these persistent symptoms. And in Chapter 9, we specifically looked at abdominal pain in remission and followed a cohort of 559 patients, of whom 429 were in remission. Among these, still 46% reported chronic abdominal pain, which is consistent with what we know from literature. And we found that having Crohn's disease, females, fatigue, depressive symptoms, and major life events were all strongly associated with chronic abdominal pain over time. Ultimately, this shows us that abdominal pain is not only common, but multifactorial, and addressing it requires us to look beyond inflammation and embrace a truly holistic approach. With that, I come to my conclusions. In part 1, we started at the top of the ski track, looking at disease scores, and showed that information from tissue biopsies could guide our first decisions. And in part 2, further down the slope, we faced the challenge of balancing effectiveness with safety, with special attention to infections. And in part 3, even when inflammation was under control, we encountered another obstacle, persistent symptoms in remission. And together, these stages show us that the journey of IBD care is not only about controlling inflammation, but about moving towards comprehensive disease control, and a need for a patient-centered approach in that journey. And with that, I give the word back to the Prorector.
Thank you, Mr. Ardabili, for a clear summary of your thesis. The opposition will be opened by the chair of the Thesis Assessment Committee, Professor Astrid van Tubergen, and she is a professor of outcome and innovation in rheumatology practice at Maastricht University. Professor van Tubergen, het woord is aan u.
Dear candidates, first of all, I would like to congratulate you and the supervisors for this wonderful piece of work. It was truly a pleasure to read, and you have taken a broad look at the management of IBD, and these insights can greatly help you and your colleagues in further personalizing treatment, improving its safety, and also offering holistic care. So my compliments for that. Now, I would like to discuss with you the chapters on the PRIQ. In Chapter 6, you describe the development and validation of this questionnaire, and you find an excellent sensitivity and specificity, almost too good to be true. So let's dive into this, because possibly bias could have occurred. On page 137, you describe that 584 consecutive IBD coach users were included in your study. And my first short question, short answer please, is how long did you follow up these patients? Was it a full year for every patient, or was the total study duration 1 year? And how often did you ask this question, or did you present this questionnaire to these patients?
Highly esteemed Chair, thank you for your kind words and your question. To give you a short answer, we followed, the study duration was 1 year, but these were existing My IBD Coach users.
Yeah, I thought
so. So these were not new users, so they were used to filling out the questions every couple of months. Yeah. And this questionnaire came back every 3 months. So that is why we could achieve this 1 year. And
so you had 1 year study period, and every 3 months they had
exactly, exactly. But some patients, of course, dropped out. As in every study, some patients, of course, dropped out.
Yes, that's exactly my question, because now I saw on page 141 that in total the questionnaire was completed 1,386 times, and if I calculated it for you, this should have been 2,336 times if all patients should have done that every 3 months, which means there's a response rate of about 60%.
Exactly.
And my question is, could possibly attrition bias have occurred? So meaning that some patients dropped out along the way, or were there also patients who did not complete it at all? Do you know anything about that?
Yes, so this is always an interesting thing with remote monitoring, which you also have a lot of experience with. So of course, what we often face in clinic is that patients that feel well don't want to fill out the questionnaires, and these are these patients that often also don't want to come to the outpatient clinic. So we don't have the specifics I don't have the specific data as to who didn't fill out.
Okay, because I really would have liked to know more about those people.
But most often these are those patients that get the questionnaire, get the invitation to do these questionnaires, but they feel well
And do you know if it's really because feeling well? Could it also have been because they had so many terrible comorbidities, or maybe
Yes,
they were lower, had a lower
course.
education, maybe they were not digitally very
Skilled,
educated, skilled,
Yeah, so that's another good point. So, of course, there could be factors also when someone has too much going on in their lives, they don't even want to fill that out, or some of our older patients sometimes struggle, but those patients actually get help from family to fill it out. Okay. So it's mostly from my experience, it's most often the younger people and the patients that do well, that sometimes they forget or just don't fill it out. Yeah.
And I had a little fear. Did someone die during this period? And maybe due to an infection, and you couldn't have covered that. You can't find it because the patient is not able to complete
to be able to answer that question, we know, and no one died, but because for all these patients, I also cross-checked the hospital records. Okay. So I made sure that they weren't presented or admitted to the hospital for a severe infection or either death. So that was not in question. Yeah.
Okay, I'm satisfied with that. And another type of bias that could have occurred is sampling bias. I mean, you have your IBD coach population, but I think only about 20% of my IBD users were actually in this study involved. And are these representative for the total population?
Yes, that's a very good point. So ideally, we would have to a population-based sample, like we have with the IBD-SL cohort. But the good thing is that even though this was a subsample of that whole cohort, if you compare the baseline characteristics to what we know from our population-based cohort, they match pretty well. So even though it's not a population-based cohort, we think this subset is representative. You always have to be cautious when making conclusions about generalizability. But I think this is a well enough representative cohort for our region, let's say.
Okay, perfect. And then another type of bias is recall bias. You also mention it in your thesis. And 3 interviewed patients indicated they were worried about this. Did you explicitly ask about this to every interviewed patient?
Yes.
You did?
Yes.
And only 3 were worried about this?
Yes.
And for you yourself, can you remember if you've had an infection 3 months ago?
Yeah,
for example, cold or whatever.
We actually had a lot of discussions about this, but because this is a very important point. We thought, well, we have to balance how many times are we going to overload a patient with giving them a questionnaire, but also measuring a concept that someone can recall for 3 months. Yeah. So if you ask me what I ate last week, I cannot tell you. But with infections, we balance that to know that looking at the prevalence and the incidence of infections, and the incidence mainly, that this is a concept that's okay if you measure that in 3 months. And that also, for practicality reasons, that aligned with the frequency of our other questionnaires. Yeah. So we had to find a middle ground in that. So it's both practicality and both measuring a concept that is feasible within that period. Yeah. But I agree, we had discussions about those 3 patients, yeah.
I don't think I have much time. I have some time? Yeah, sure. Okay. Because I wanted to ask you some questions about Chapter 7. Mm-hmm. In the first table in Chapter 7, you describe your population. But I think one important variable is actually missing, and that's vaccination status. And I was wondering, could this have a significant influence on the outcome if it was included in your GE model? What do you think, if you know more about this?
And a very good question and very valid question, because, I think this is an important limitation. I would say I don't think it would have altered our conclusions, but I think it could have been some residual confounder we have missed and we could have included. But that's something we definitely tried, because that's something we do not currently ask. Yeah. And that's something we should start asking, I guess, and then we can make some more granular comparisons.
Thank you. I'm satisfied with the answers, and I'll give the word back to the prorector. Thank you.
Thank you, Professor van Tubergen. The next opponent is Professor Gerard Dijkstra. He is present here, not in this room, but online, as you see. He's professor of inflammatory bowel disease and intestinal transplantation at the University Medical Center Groningen. Professor Dijkstra.
Thank you, Mr. Rector. Dear candidate, of course, I also want to congratulate you and your whole team. Again, a great thesis from the IBD South Limburg cohort. It's really comprehensive because it's a thesis from biopsies to irritable bowel syndrome, so it's real comprehensive. And I considered you actually as a young talent, a young talent who will set the stage in future IBD research. So I read your discussion with great interest and also your impact analysis. So that's why I want to discuss with you that, and I want to do that first with the first proposition. And so in the absence of reliable prognostic tools, the patients just have to try. And then you say, yeah, that means that we'll have a lot of risks for undertreatment and overtreatment. I want to start there. What do you consider overtreatment?
Highly esteemed Chair, thank you for the kind words and your question. I think overtreatment is a concept that lives in the field, but no one has a clear definition for it. But it usually pertains to that we know that there is a group that has a mild course, and those patients may only need monitoring, or they could be even treated with, let's say, a thiopurine or a 5-ASA, depending on the disease. But we currently don't know that yet from the outset. And in the current era, where with these many newer drugs, we tend to move towards maybe anti-TNFs more easily, more quickly, and a lot of those patients might not even need them. So overtreatment, in my sense, is giving a patient a treatment that he might not need for them to disease to stay stable or on track, let's say. Okay, so it's course related. Yes. And so a mild course probably. So the question is that true, of course, because what do you think about if you have an expensive drug, it works, so the gut or heals, but it's still an expensive drug. Do you consider that as overtreatment? No, I wouldn't. That depends on who you ask, but I guess for me, overtreatment is more as in giving too much medication when it's not needed, rather than looking at cost. But if you would ask, if I would include sustainability in there, then yes, and expensive drug would also consider overtreatment when we can do that with a less expensive drug. Okay, and then coming back to your thesis, because it's the first proposition, what in your thesis would improve or to minimize this overtreatment? So can you have some suggestions? Because I couldn't read it in your future perspective. So what do you think will be a strategy to overcome it? What will be the best strategy, even from your thesis or something else? I think my thesis has given some insights, but not necessarily something that is ready for practice yet. And I don't think we have anything that is ready yet for practice. I think we're all very, very much working on that. We're always on the look for more predictors, but actually, for example, you also published last year that even if you add microbiome to clinical characteristics at the outset, it doesn't improve our prediction that much. So I guess until we find something that can tell us more about the outlook of patients, we're still facing that we don't know if this patient would have progressed without or with. And if I have to think about some strategies, well, we have one trial in our center currently that's running. It's the COCRAS trial. If you look at treatment cycling, you could perhaps think, if you don't know yet, you could play with how you give the therapies. You can see after induction if someone has gotten to their endpoint, and you get them off the medication and see if they remain stable over time. And if they remain stable, that a group may actually belong to the ones that were mild, that only needed the first hit. But these are all strategies and hypotheses at the moment. Yeah, and what do you think about cluster randomizations? That we, for instance, in the north apply a certain strategy, and you're in the south, another one, in the west, another one, so that we have a cluster strategy trial in the Netherlands to see which strategy is best? Yes, I guess we need practice-changing trials, and we're currently I just returned from a couple of months over in the States, and what stuck with me is that my mentor there said, we have enough drugs. We don't know how to use them well enough. And I think we need trials to actually see how we can change our practice. We need to think about out the box. We need to get rid of is a big word, but we need to minimize on placebo-controlled trials. We need to actually dare to see if our newer medications can face them against infliximab, for example, and let's see what happens. But I guess there is too much pharmaceutical stakeholdership there that prohibits that from currently happening. But yes, I guess that's something, and we could work on that in the future, of course.
I fully agree with you. Then I want to go to proposition 8. Can the paranymph read proposition 8?
So number 8 is precision medicine is the Loch Ness monster of IBD. Everyone talks or writes about it, but no one has ever seen it.
Yeah, thanks. That's a great opposition, of course, a great proposition. What do you mean by precision medicine? Do you mean personalized medicine? So can you explain a little bit more? And you say everybody talks about it, nobody has seen it. So
yes, so I guess, yeah, it's an important point, because there's a lot of misconception in the field, because there's something, personalized medicine and precision medicine to me are two different concepts. Personalized medicine is actually, things such as shared decision making, tailoring your decisions based on data that we know. But precision medicine, and I'm sure I can think of two things or maybe three things we have precision medicine in the field, and that is the TPMT that we have with the thiopurines. And there was this thing where we could look at if anti-TNF, the ALH5QD, but we don't have anything else with regard to precision medicine currently in IBD. And precision medicine is actually, if we look at the field of oncology, they use a lot of precision medicine. For example, gene mutations or differences between patients to which they tailor therapy. And I guess that's where we want to go, but we currently don't have that in our field.
Yeah, I agree with you. But still, if you look at your thesis, didn't you have seen it? Because your thesis is personalized medicine, is comprehensive, looking at all holistic view. Could you agree with me that your thesis is a personalized strategy?
Yes.
You may give a short answer, please.
Yes.
Okay, thanks. I would give it. Thank you for the answers. I enjoyed it. I will give the word back to the rector.
Thank you, Professor Dijkstra. The opposition will be continued by Professor Erik Schoon. He is a professor of endoscopic oncology at Maastricht University, and he is affiliated with the Catharina Hospital in Eindhoven. Professor Schoon, the floor is yours.
Mr. Prorector, dear candidate, I'd like to congratulate you and your promotion team with this wonderful comprehensive thesis and the results achieved. I read it with great interest and pleasure, and I'd like to change thoughts with you and elaborate of the potential clinical implications of your thesis. And we'd like to start with chapter 2. It's a chapter on the pathological features of colonic biopsies, diagnosis to predict long-term outcome in Crohn's disease. That's the title. And you describe the potential predictive value for the disease cause. And so you create a model, and you very nicely demonstrate the increase of the area under curve and the increase in sensitivity and especially specificity on page 45. And so I'd like you to explain to me what does the sensitivity and specificity mean for the prediction and for the patient.
Highly esteemed Chair, thank you for your kind words and your question. Well, the goal of Chapter 2 was to get a prediction model. So when we want to get a prediction model, we basically, the first step was that we looked at clinical characteristics, and we looked at the additive value of these biopsies, or these features in the biopsies you just described. But the goal of the prediction is not so much the sensitivity and the specificity. It's actually when you look at the table after the area under the RSC curves, is the predicted probability formula we get from that. So basically, if for each patient you can fill out that formula, and it gives you the predicted probability of them getting a severe or a mild course. So the sensitivity and specificity is just what we found in our sample. The PPV and MPV is more interesting, but that's always depending on your prevalence, and because we only looked at mild and severe, that's not reflective of the whole population. So it tells us something about the test characteristics of our model, but the most interesting is our predicted probability formula.
Okay, thank you very much. If I may interrupt you. So, yeah, you write it in your chapter as well, that the high specificity is important to prevent the misclassification and potential overtreatment. And we discussed the overtreatment before Professor Dijkstra. But the histological classification, is it not mirroring the endoscopic severity in the large picture?
That's an important point. So, but we see that in the strategy we had, because it's a retrospective study, we looked at the biopsies throughout the whole colon, and we didn't look at specific areas where there was disease activity.
Can I interrupt?
Yes.
Were the biopsies taken according to a certain protocol?
No, so that's the bias of, or the limitation with retrospective study. They were taken based on clinicians' judgment. But to overcome that, what we did is we looked at if there, for example, was a colon ascendens biopsy and a transverse but no descending biopsy. We looked at basically the pathologist scored the features where they could be scored, and then we applied a worst case approach, meaning that if the ascending showed severe lymphocyte infiltration and transfer didn't show that, the total score would be severe lymphocyte infiltration. We try to overcome that, but that's an important limitation.
Yeah, well, I agree. That is a kind of approach. So you find the Paneth cell metaplasia as one of the main important factors in Crohn's disease. Do you agree?
So Paneth cell metaplasia is actually, usually if you find it up until the right colon, it's physiologic. But if you find it from the ascending colon onwards, it's a sign of, usually Paneth cells are our antimicrobial defense barrier. But if you find it in the places in the colon where there shouldn't be, that actually is a sign of that there has been something, chronic inflammation going on, and that these crypts have been changing to adapt to that. So yes, I agree. I think that's an important sign of chronic inflammation.
You developed a nice model. Is it used in clinical practice yet?
Before we externally validate, I guess not.
Are you validating it prospectively?
Not yet, but we plan to.
In the patient's selection, you described smoking as a risk factor in the population, but that doesn't come out in the model as a risk factor.
Right. So yeah, that's also the statistical part, I guess, of it. Yeah. So if you try to find your best prediction model, sometimes the predictors that come out univariably lose their statistical significance in the multivariable model. But we know that smoking is a risk factor for developing a severe disease. So I agree with you on that.
Yeah, because we had publications from the same IBD group, which demonstrating smoking as a risk factor for severe disease. Okay, thank you very much. I'd like to, if I have some time.
You have time for a small question and a sharp answer.
Okay, well, I go to one question which, we go to chapter 9. In chapter 9, you describe the abdominal pain in patients with IBD, contributing factors, and I miss one important factor studied in this. Can you think which one?
Are you pertaining to the patient characteristics or?
Yeah, patient characteristics, yeah. And something, you have the disease location, duration of disease, anything, family history.
Maybe their psychiatric history or?
Medication. Medication is not here. And
Yeah.
why? Well, 30 years ago, when I was working here, we give the first patients, we give them anti-TNF. And we saw some patients who were severely depressed, and the depression was gone. So we thought the cytokines might be influencing.
Yes. Good point.
And so
Please
I'm interested.
keep it short.
Yeah. I'm interested in the patients who are on chronic anti-TNF, and do they have a different? Are they different than the other patients not on anti-cytokine?
Unfortunately, I don't have that data, but it's a very good suggestion.
So it's time for another study.
Yes.
Okay, thank you very much. I give the word back to the prorector.
Thank you, Professor Schoon. The opposition will be continued by Professor Kirch-Gessner. He is Professor of Gastroenterology and Epidemiology at the Saint-Antoine Hospital in Paris, France.
Dear Prorector, so dear candidate, so I would like also to compliment you for this great presentation and all your team with this piece of work, which is impressive, I should say, and very comprehensive regarding the IBD therapeutic management. So I will mainly focus my questions on chapter 7, so regarding the infections. I think this, as you said, I think this is very important to assess the risk of mild infections, as there are very few data in the literature to assess this outcome, which could have a high impact on patients. And I have some questions regarding the methodology. As you try to adjust for IBD's activity, we know that this is a risk factor for serious infections, at least, but also potentially for mild infections, we could guess. And in your study, this activity was based on fecal calprotectin, so which might be a better marker of inflammation rather than clinical symptoms. But for some patients, still, we know that fecal calprotectin might be not very sensitive. For example, Crohn's ileitis or ulcerative proctitis. And at the end, it was not associated with an increased risk of mild infection, so the IBD activity based on fecal calprotectin. So do you think that it's the literature which might be wrong related to the risk that has been shown because it's mainly related to clinical symptoms in the literature? Or do you think that the impact of intestinal inflammation should be underestimated regarding the risk of infections? What are your guesses related to this risk factor?
Highly esteemed Chair, thank you for your kind words and your question. I guess for these for these serious infections, as you touched upon, we know that disease activity is clearly a risk factor. But for these milder infections, we don't know. And we actually we had a composite endpoint for the disease activity. It was a combination of a clinical score and the biochemical endpoint, which is calprotectin. Based on the reviewer suggestion of the paper, we also did the other way analysis where we prioritized calprotectin. And we then saw in the sub-analyses, we saw a signal for disease activity, but it's not that strong as you would expect that we see with the severe infections. So it could be less of an important factor for these milder infections. And for these severe infections, it could be a more important factor.
Okay. And also regarding if we come back to serious infections, for the incidence rates, I think it was really high compared to the literature because it was around 4 per 100 person years. While if you look to the literature, I think twofold less, so around 2 per 100 person years. I know that, of course, the sample size is small, so it's difficult to really interpret the results compared to other studies. But do you have any insights? Why did you have so many serious infections in your study?
Yes, so I agree with that point, and that's something that also caught our eye. When you have a smaller sample, you don't have the patient years of exposure to accumulative patient years exposure to look at these severe infections in enough detail because you need enough patient years of exposure. And when you have this small number, we only had 25 severe infections, so meaning that every change, 1 or 2 above or a couple higher or lower, can drastically change your incidence rate. So even when we excluded the GI infections, which was also what a reviewer suggested, it dropped down to 3.5, but it was still higher than what we expected to be in literature. But it has to do, and I agree with you, that this study is not as well designed to look at these severe infections and more to these mild and moderate infections.
Okay. And so if we come back to the confounding factors, we know that comorbidities, of course, is a confounding factor regarding the risk of infections. You use the comorbidity score, so which is the Charlson Comorbidity Index. Do you know how was assessed the Charlson Comorbidity Index, in which population it was developed, so, and when? Do you have any idea?
No, and I don't have an idea, no.
Okay. So, because it was in the 80s in the HIV people to assess the risk of death, so in the US. So basically this is mainly widely used across the studies to adjust for comorbidities, but I think it might be not the best comorbidity index, at least. I understand why you try to combine in one variable all the comorbidities. But so my advice would be to, if you have the sample size, of course, to try to adjust for the individual comorbidities that are relevant for your study, or to try to use other comorbidity score that might be more relevant regarding the weighting of each comorbidity. So exactly. This is just a short comment. And my last question would be regarding your outcomes. So mild infections, so you assess the risk of one unique mild infections, but I think in a clinical practice, what would be more relevant is to assess the cumulative risk. So patients who are experiencing several mild infections, because this is the main issue that we are facing. So patients who are coming every 3 months, 6 months, saying that they have, again, a mild infection. And this is the patient who would like to switch to another drug, which might be less associated with a risk of infection. But we don't know, of course, if the drug is effective. So there is always this balance between the effectiveness of the drug and the safety. So is there any model that could have been used for your study to try to assess this additive risk, to assess the mild infections that are occurring several times during follow-up?
Yes, so the current methodology, to my knowledge, accounts for the number of counts, but it doesn't account for the additive value you're describing. So there are different methodologies, and we also discussed this, and it could be the marginal structural models, for example, and they do a bit of a better job at looking at a patient specifically rather than what the GEE model does. It gives you a population average, and the MSM more looks like to the patient specific, and that's, I guess, what you're pertaining to, I hope.
Yes, and also the Poisson regression, I think this is also a way to
exactly
assess several infections for the same patients during follow-up, so it could be also another model. So I'm finished.
Thank you.
That's quick. Thank you very much, Professor Kirchner. The next opponent is Professor Paul Savelkoel. He is Professor of Medical Microbiology at Maastricht University. Professor Savelkoel.
Well, thank you, Mr. Prorector. I also want to start with congratulating with this very nice piece of work, also centralizing the patient. I think that's very good in these complex diseases. And I also want to include, of course, the promotion team. I think it's a marvelous job which you did, so thank you. Very good work. But as a microbiologist, I always look in these booklets whether there are any microorganisms present, and they aren't. Unless I had to reach, I think, around chapter 8, in which you are saying that there's no role for them. But if we're looking at IBD, we all know that there's, of course, a close bidirectional action of the nervous focus between the brain and the gut microbiota. And in IBD, you also know that there's a complete dysbiosis of this microbiota. Normally, it should be an equilibrium, but that's gone. And that also leads to leakage of the gut, with all kinds of effects. So my first question is to you, do you see a role of microorganisms in the treatment of IBD?
Highly esteemed Chair, thank you for your interesting take and your question. So if I may rephrase you, are you saying that targeting microorganisms to treatment specifically?
For example, I don't know your opinion. You're the expert now.
So well, there have been some tries in that field. So the MOP, so the Mycobacterium paratuberculosis, has been very spiked the last couple of years. But that interest also has died down a little bit again. There was some interest around that, but no one has actually. There are people that believe that IBD is an infectious disease or is partly an infectious disease, and have tried to see if they can find a cure in that sense or be able to treat it, but they haven't been as successful. I fully agree with you that there is a role, but that we haven't deciphered.
That's nice to know, anyhow. So.
But we haven't deciphered that yet.
Yeah, I can understand because we have also, there were a lot of initiatives, of course, but as you also state, every patient is different, but also the microbiota composition of every patient is specific for that patient. So you must go to a more personalized treatment. Do you think that's possible, looking from the microbiological perspective?
So the difficulty in that is that we know everyone has a different microbiome, and even someone with inflammation has a different microbiome than someone that doesn't. But in IBD, we also have the more complicating factor that our medications also then alter the microbiome. Yep. So our medications then also have an indirect microbiome drug relation, and they are either metabolized by the microbiome, or the drugs have an effect on the microbiome. So it's really complex. And I don't know, because of the heterogeneity we have, if we are able to find something there. I guess we should try, and it hasn't been tried that extensively yet. But in Groningen last year, they published something about the additive value of microbiome predictors to clinical parameters to predict treatment response, and they didn't find anything. But they didn't find an additive value. So I guess there could be, but it's so complex with all these different factors influencing each other. I don't know if we will be able to find it the way we're currently doing it.
Yes, but the techniques, of course, proceed,
yes.
So there are more possibilities.
Exactly.
But just I understand that you would give it a try, at least. On the other side, there's a leaky gut, of course, when you have this change of microbiota, and then you are looking at mild symptoms, etc. Do you think that the level of leakiness, so to say, could influence that you have more mild or less severe infections?
So also an interesting take, because there is a lot of debate about this leakiness. There is a part of our field that doesn't believe in it at all, and there is a part of it that strongly believes in.
It's science.
Yeah, so, right. So with that, I guess. Yes, there could definitely be a role, but currently we don't use measures to measure like barrier permeability in our patients. We use it in research settings, but we don't use it in clinical practice. And I guess if in clinical practice in IBD, let's say, could it predict someone getting an infection? I don't know if it predicts you getting an respiratory tract infection or a skin infection.
There are, of course, examples showing that this influence each other.
Exactly. So your gut microbiome then influenced your skin microbiome.
Yeah, exactly.
So yes, but I guess it's worth also looking at that, but I'm not sure how we would do that.
No, and then another aspect, which, because if you have the drugs now, then it's more a systemical attack of IBD. So when you find, let's say, a specific bacteria which you can add to a person, you get a local reduction of the immune response. Mm-hmm. Wouldn't that be better than this whole systemic inflammation reduction, or do you think it should be systemic?
No, I guess we have currently we have. I would say not all of our drugs work systemic. We have one gut-specific, as so we call vedolizumab. It works to T cells that specifically circulate in our gut region that have specific receptors. But those only work also they don't work in everyone. They work in a subset of patients. Yeah. So that's the issues we face. Of course, the local or targeted therapy is way better than suppressing one's whole immune system. I agree with that.
Yes, okay. I see a lot of research in the near future, and I thank you very much for the discussion. I give the word back to the Prorector.
Thank you, Professor Savelkoel. The sixth and last opponent is Dr. De Rijks. He is working at the Maxima Medical Center, and he is expert in hospital pharmacy of IBD. Dr. De Rijks.
Thank you. Dear candidate, first of all, I also would like to congratulate you and your supervisors on this impressive body of work. Your thesis covers an exceptionally broad spectrum from real-world effectiveness and safety of immunosuppressive therapy to the development of digital monitoring strategies in inflammatory bowel disease. And as a clinical pharmacist, I'm particularly interested in the effectiveness and toxicity of drugs. I was going to ask you some questions about Statement 8, but Professor Dijkstra beat me to it. The only thing I want to say is I think it's not the monster of Loch Ness, but the Northern Light, which is existing but rare, but less rare if you know where to look. And you will forever talk about it once you've seen it. But now to Chapter 3. You assess the effectiveness and safety of thiopurines, and these drugs sort of became my hobby the last 25 years. You define in this chapter effectiveness as the absence of escalations to biologicals, corticosteroid use, surgery and hospitalization. But given that the IBD South Limburg cohort lacks systematic biochemical and endoscopic data, which are considered the golden standard, how do you address potential misclassification bias?
Esteemed Chair, thank you for your question. So with doing these sort of long-term effectiveness analyses, when we started the analyses, looking back, and we had a very long term of follow-up, in those first years, we didn't even use calprotectin or biochemical data. So we had to find a proxy for effectiveness. And you could argue that this more looks at treatment persistence in some sense, but I guess with the combined effectiveness endpoint we made as the things you mentioned, the escalation to biological therapy, corticosteroids, etc., that is an indirect measure of effectiveness. Of course, would have been better to have more objective measures such as an endoscopy and biochemical factors, but because they only were selected in a part of our whole cohort, we couldn't use them.
Okay. And if you look at the biological era, how can we be confident that the finding is not explained by confounding by indication, by changing treatment thresholds over time?
Yes, so we expected, so we did an analysis where we stratified for pre-biologic era and biologic era, because you could expect if you don't have the option to prescribe a biologic, you try to keep your patient on a thiopurine. So we try to see whether, if in the biologic era where the clinician had access to giving a biologic meant they would switch earlier. But there is one of the Kaplan-Meier curves, I don't recall precisely, that shows that even if you stratified for pre and biological era, there is no statistical significant difference.
Okay. And what about the effect of pharmacogenetic testing and therapeutic drug monitoring, which was introduced in this same era?
Right.
Did you account for that?
No, so that's also mentioned in our discussion. It would have been very nice to get data on TPMT, because I guess we could have even and even better use of our thiopurines with split dosing or allopurinol co-administration, etc. I think we could have even reached better rates, but we had to do it with the data we had at that time, and we didn't have the TPMT back then, or only introduced like in a short segment of that follow-up. So yes, I guess there's room of improvement. If we repeat that now with the data we have, or started in the era, we can see maybe even some better rates of effectiveness.
Yes, and I think drug survival may be even better for the thiopurines in this era, because we use those instruments. Now to safety signal interpretation, I would like to address another key aspect of 3, namely treatment safety. And this section of your thesis evaluates a long-term incidence of malignancies and other adverse events associated with thiopurine exposure in the IBD South Limburg cohort. And I think the interpretation of such real-world data is crucial. But however, such a risk may depend on cumulative exposure, treatment duration, and patient age. Did you address for these?
So yes, we looked at, we know that after 12 months of, the most of the risk with thiopurines starts after cumulative of 12 months of exposure. We know that from literature, particularly pertaining to non-melanoma skin cancers. We know that from that literature that someone needs to have at least 12 months of cumulative exposure. It doesn't need to be continuous exposure. But we addressed that in our safety analyses. Only the patients were included that had 12 months of cumulative exposure.
Okay. And if I have another question left, I would like to ask one more about chapter 4. If an infection screening approach were to be implemented in routine daily care, what key factors should be considered regarding frequency, severity classification, and validation? What do you think?
So you mean when we implement this into care?
Yeah, exactly.
I guess our PRIQ is ready to be implemented in clinical care. It's already being used in clinical care, and I guess it's just about getting it to a larger population that we have now. So currently it's being used across all the hospitals in the Netherlands, and the next step is to not only look at data from our region, but look at the data from the whole Netherlands, and to see, and the most interesting question to me is that if we look at these mild infections and your moderate infections, are these also predictors for getting a severe infection in the future?
Yeah. Okay. I think I'm satisfied with your answers, and give the word back to the prorector.
Now we have to wait for the Beatles to come in.
They forgot the time.
Unless someone of you has an interesting question left.
So let's go for it. Now, you have done several of your studies during the COVID pandemic. And there she comes. So I'm going not to ask this question.
As you hear, Dr. Ardabili, the time for defending your thesis has passed. The committee will now withdraw to discuss the quality of your thesis, and in particular the quality of your defense, and please await our return here. Mr. Ashkan Rezazadeh Ardabili. The degree committee here present has assessed the quality of your thesis and the quality of your defense, and in view of its positive verdict and taking into account the previous qualifications that you have achieved, the degree committee has decided to grant you the degree of doctor. And Professor Jonkers is authorized to confer upon you this academic distinction in accordance with Dutch university custom and law. And invite now your supervisor, Professor Jonkers, to take the floor.
Please all rise.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Ashkan Rezazadeh Ardabili, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary and the other members of the committee and affixed with the official seal of the university.
Dr. Ashkan Rezazadeh Ardabili, it's a great honor to be the first to congratulate you and to address you by your well-deserved new title. My warm congratulations also go to the rest of your PhD committee, to all the colleagues, friends and family of Ashkan, and especially to those who have joined us from abroad, whether here in Maastricht or on the live stream. As the saying goes, it takes a village to raise a child, and likewise it takes a community to successfully and joyfully complete the PhD journey. In the written text, you can see that I did my best to open in Persian, which went about as well as you might expect. And so I decided it's safer and certainly more heartfelt to deliver this laudation in my own language. So Ashkan, from here, it's Dutch only. Als je door jouw proefschrift bladert, zie je een skier. Elegant zigzaggend de berg af, telkens iets dichter bij de finish. Dat beeld is treffend, want ook jouw wetenschappelijke reis was een afdaling vol focus, precisie en af en toe een gewaagde sprong naar de Thioperines. Ik leerde jou kennen nog voor je aan je promotietraject begon. Een nieuwsgierige, gedreven jongeman met een eindeloze stroom van vragen. Je ouders, altijd trots en betrokken, vormden steeds de stevige basis van waaruit jij vertrok. Met jouw brede wetenschappelijke achtergrond zagen collega professor Deze Jonkers en ik meteen dat je de perfecte kandidaat was voor een uitdagend onderzoeksproject in het laboratorium. En daar begon nog tijdens jouw studie onze samenwerking, die resulteerde in de eerste paper van deze thesis. En tijdens die eerste stage op ons lab groeide dit idee om een promotietraject te starten met een meer klinische insteek. In nauwe samenwerking met Marielle Romberg en ook de andere collega's uit het Zuiderland groeide dit uit tot een prachtige onderzoekslijn binnen onze IBD-groep. We leerden jou kennen als erg gedreven, perfectionistisch, nieuwsgierig en als een sociaal netwerktalent. En deze kernkwaliteiten vormen de leidraad om jouw wetenschappelijke slalom binnen ons team een beetje verder toe te lichten. Jouw proefschrift Towards Comprehensive Disease Control for Inflammatory Bowel Diseases richt zich op een vraag die elke arts bezighoudt, maar die zelden eenvoudig te beantwoorden is. Hoe bieden we de juiste behandeling aan de juiste patiënt op het juiste moment? Een proefschrift dat de lat hoog legt, van louter ziektebeheersing naar echte ziektecontrole, medisch, mentaal en menselijk. Ashkan, je bent een skier die niet remt. Je gedrevenheid zorgt ervoor dat je minder bochten maakt dan de illustratie in je proefschrift suggereert. Je bent eerder een downhill racer dan een slalomspecialist. Je kiest voor snelheid, weet wat je wil, werkt hard en gaat recht op je doel af. Dat is bewonderenswaardig, al vroeg het promotieteam zich soms af of downhill racen altijd de juiste discipline was. Want in zo'n razendsnelle afdaling kun je soms de omgeving in het oog verliezen. 4 maanden fellowship in New York bij professor Colombel. Indrukwekkend, maar ook een uitdaging voor Naomi en voor je dochter Alba thuis. Gelukkig zal het niet lang duren voordat Alba zelf haar eerste skis onderbindt. En dan, Ashkan, zul je merken dat ook kleine bochtjes samen met haar een vorm van perfectie zijn. Ashkan is niet tevreden met goed genoeg. Ooit wilde hij tandarts worden. Vrij logische keuze voor een perfectionist. Maar gelukkig voor ons zorgden de omstandigheden ervoor dat het geneeskunde werd. 2 masters, een doctoraat, 2 drukken van het proefschrift, want de kleur van de eerste kon nog net iets beter. Zelfs zijn appartement is tot in de puntjes georganiseerd, wit, strak en vermoedelijk alfabetisch geordend. Dat perfectionisme heeft echter veel moois voortgebracht. Diepgaande analyses, zorgvuldig opgebouwde studies en publicaties die stevig staan. Het leverde hem nominaties en prijzen op en een plek in de International Young Talent Groep van de European Gastroenterology Association. Ashkan weet alles, of zoekt het uit voordat iemand het hem kan vragen. De IBD maandagochtendpodie begon stevast met: Marieke, heb je dat artikel al gelezen? Dat was dan 30 minuten nadat het in de preprint online stond. Of Marieke, ik weet nog een leuke roddel van Echo. Ashkan weet bijna altijd alles eerst. Die nieuwsgierigheid maakt jou niet alleen onze wetenschappelijke radar, maar ook de onofficiële nieuwsredactie van de MDL in Maastricht. Het is jouw motor, het vermogen om verbanden te zien waar anderen nog bezig zijn om de puzzelstukjes bij elkaar te zoeken. Ashkan is een geboren netwerker. Hij beweegt zich moeiteloos in elke context, of het nu een congreszaal in Wenen is of mijn woonkamer in Jeuk. Gedurende zijn PhD-traject was hij actief betrokken bij verschillende organisaties, zoals de IBD-commissie van onze wetenschappelijke vereniging. Tijdens de COVID-periode organiseerden we zelfs een mini-symposium, een mini-congres, onze eigen mini-echo, om aan Ashkan zijn netwerkbehoeften te voldoen. Ashkan met zijn oral boven op het bureau, de rest van de onderzoeksgroep onder supervisie van Daisy in de huiskamer en ik beneden als chair vanuit de keuken. Het ging heel goed. Ter illustratie ook nog, tijdens een ECHO-congres na de laatste presentaties en vlak voor de General Assembly kwamen Laurens Stassen en ik in de faculty bar jou tegen. De gemiddelde promovendus zat op dat moment al lang met elkaar en de andere Nederlandse PhD achter een biertje. Maar jij, Ashkan, was omringd door een grote groep internationale collega's en key opinion leaders en zei: Marieke, zal ik je even aan iedereen voorstellen? Nog nooit meegemaakt. Ashkan, je maakte vele internationale contacten en vrienden, wat ook blijkt uit de aanwezigheid van professor Julian Kirchner hier vandaag, waarvoor veel dank. Gelukkig ben je niet altijd de skier die alleen maar recht op zijn doel afgaat. Tijdens ICC-etentjes, eco-parties, lab-uitjes en UEG-feestjes en zeker op jullie prachtige bruiloft heb ik gezien dat je ook kunt loslaten, lachen en genieten. En vandaag, Ashkan, kom je over de finishlijn als een bevlogen onderzoeker, maar ook als liefdevolle partner van Naomi en trotse vader van Alba. Je hebt elke poort geraakt, soms met een sprongetje, maar altijd met stijl, precisie en een glimlach. Dus namens Daisy en Marielle, de hele onderzoeksgroep en alle collega's uit Maastricht en het Zuiderland, van harte gefeliciteerd met deze prachtige wetenschappelijke slalom. Er liggen gelukkig alweer nieuwe bergen op je te wachten. En wij kijken er naar uit om je volgende afdaling te zien als dokter Rezazadeh Ardabili. Okay.
Esteemed Dr. Ardabili, dear Ashkan Rezazadeh, I'm happy to congratulate you with your doctorate, and I congratulate you also on behalf of Maastricht University. I also would like to share some impressions of the committee with you. First of all, we have seen and heard a very clear presentation of a summary of your thesis. This presentation is meant for those people who are not experts in the field. And I think, and I hope, and I'm quite sure that you very well understood where Rezazadeh has been working on the last couple of years. And this is not only very good, but it's also something that the university appreciates, because it's important that the universities make clear what their PhD students and other members of the university community are doing. With respect to your thesis, we have read an excellent thesis with a broad spectrum of studies and a broad spectrum of methodology. And also, we have also seen an impressive list of publications in scientific literature. With respect to your defense, well, we are aware that you got quite a lot of different questions, maybe also not all that easy, but you gave, if I may comprise that in a few words, comprehensive, sharp, quick responses, confident, fluently as well. And also we have seen that you had a great understanding of the background and also the content of all your studies. You have clearly shown that you are very well able to perform scientific studies and an excellent clinical performance. And we are very satisfied with your defense. I would like to add one aspect. As being one of the persons who were at the cradle of the ACO master, I'm very satisfied that I've seen another PhD student acquiring a PhD.
Thank you.
An ACO student who was acquiring a PhD.
Thank you very much.
I do not only want to congratulate you with that, but also your 3 supervisors. And now I have the list with me. Professor Daisy Jonkers, Professor Marieke Pierik, and Dr. Ron Bergkamps. Congratulations with the results that we have seen today. And I also want to congratulate all your family members, and in particular your parents and close family members sitting here proudly on the first row. Congratulations what you have seen today. I would also like to include in my congratulations the audience here. I'm sure that quite some colleagues and friends and other people knowing you are here present in the aula, and also our followers on the live stream. I would like to thank all members of the degree committee. We are appreciating the fact that you are critically reading the manuscript and having generated an interesting discussion with your questions. And I would like to especially thank the external members of the committee. Maastricht University appreciates your contributions. Thank you very much. Before I close this ceremony, I would like to invite Professor Gerard Dijkstra to congratulate you, because he is now online present, and I would like to give him the floor. Professor Dijkstra.
Thank you, Mr. Pro-Rector. Thank you for giving me the opportunity to congratulate you, Ashkan. You are mentioned Ashkan, die alles kan. And indeed, your future is very good, and we have a long-standing collaboration between the South Limburg cohort and the Northern cohort. So I hope we can collaborate in the future, because there are also some young talents here. So it's good to see that this is developing. So congratulations to you and your family, and good luck in your future career.
Thank you very much.
Before I close the ceremony, I would like to announce that we will take, after closing the ceremony, we will take a picture with Professor Dijkstra on the screen, and then we will go to the hall and take another picture on the stairs. And I would like to invite the close family to stay here, because we want you also on the picture in the hall. And I would like to suggest that the people here in the audience here in the aula will go to the rafter, where you are kindly invited for the reception. You find it quite easily by going to the left here, and at the elevator, then turn to the right, and you come automatically in the rafter for the reception. Hereby I close this academic ceremony.